Hello, everyone. This is Ziad Salami. Welcome to our webinar on DentLinks. So I'm prosthodontist, I'm professor and director of the research center at the Lebanese University at the Faculty of Dental Medicine. And I'm very happy today to share with you some of our clinical experience and research data on what is now the hot topic, which is digital dentistry, and mainly digital dentistry applied mainly in prosthodontics. And this is what we'll be sharing today. So within this coming 30 minutes, we will try a little bit to shed the light on the hot topic in dentistry, which is digital. A slide that I always like to share, and this a little bit resume how things evolved. And you see that mainly technology has changed a lot of aspects in our daily life. And this can also be simply applied in dentistry. So if you just have a look on what happened since the first prosthodontics way of dealing in 1950s up to today, so there is a drastic and significant change. And all this again was didacted by technology. So why dentists till now are a lot of time skeptical, or little time, they are afraid, quote to quote, in moving into this new era, in this new technology. Again, one of the main problem is probably in the curricula. So the curricula that was a lot of time, these books were written way long, 1950s and 60s and 70s and 80s. And again, a lot of time dentists are afraid of any change. They are okay with their comfort zone. So telling them that they have a lot of time to change drastically make them a little bit afraid. So what is the digital dentistry? It was more known a few years back as CAD/CAM technology, which is not anymore the appropriate terminology. So CAD/CAM, that's said to computer-aided design and computer-aided manufacturing or machining, is again a borrowed science, because we all know that any development in dentistry is borrowed from another industries. And the impact of the development in other industries that went up having this new technology. So you all know, from the scanning to the milling to all these small development that were applied in dentistry. Again, that was possible thanks to the development of materials also, which is very important, and mainly to the introduction of zirconium oxide or stabilized zirconium oxide into the dental field. So from, as you can see on the right side of the slide, from craftsman, from handwork up to something that is machined and using only machines. So the question to be raised is if still the conventional prosthodontics principles and concept still relevant today. So this will be a little bit the topic of this evening in talking about digital dentistry. Digital dentistry will be more focused about intraoral scanning, about impressions using intraoral scanners. But again, if we just ask dentists in the street or in a conference, just what do you want from an intraoral scanner? So they will tell you we need something with an open system, powder-free, giving some color, and the most important, cheap. And if we move to a milling side, and especially the chair-side milling, we need a milling machine with 4 or 5 axes. And for them, this is CAD/CAM. But effectively, this is not true. So again, we will be a little bit giving some points, explaining why these things have totally changed nowadays. So how the change occurred from the conventional concepts in prosthodontics, in daily clinical prosthodontics, to the digital world or digital dentistry due to the development at two ends, two sides, technology and material. So technology alone will not be able to have this impact in dentistry. Material development, and mainly on the level of full ceramic or all ceramic restoration, was important to have this well developed. So digital dentistry a little bit have four components: scanning, designing, milling, and printing if printing is needed. A question, again, very important question, if all intraoral scanners are the same, and this is very important. So we will be a little bit showing today what we are using daily in the office, at the private practice, and also at the university. And we'll be talking more about the Trios 3 from 3Shape, even though we have some experience with a very good machine also, which is the Omnicam from CEREC, from Sirona, which is a very good device for chairside scanning and milling also. So regarding the most important parameters when you are choosing your IOS or intraoral scanner is to understand trueness, accuracy, and precision. We will not be going a lot today with the small technical parameters, but you need to know that these three parameters are not the same when you are comparing different intraoral scanners that are available on the market. So if we go a little bit to the literature and comparing, because a lot of dentists are always raising the same question: are you sure that intraoral scanning or digital impression is as precise as the conventional technique we are using or we were using for the last 10, 15, 20, 30, 50 years? And if we go again to the literature, and you see that a lot of papers, among them what I'm showing now, that the way of producing chairside, and they did the comparing with chairside CAD-CAM using the CEREC and E4D devices, showed that they had better than the restoration that were fabricated by conventional methods. And again, here the operator experience did not seem to influence the accuracy of CEREC, it means chairside fabricated crowns. So most important that the literature starts showing that these intraoral scanners are as precise and giving as precision as conventional technique used. I'm sharing here a multicentric research on trueness and precision of different CAD-CAM iOS scanners and also OneLab scanners. And one of the center was in Lebanon at the Lebanese University. And we compared Trios 3, TrueDef from 3M, the iTero, PlanScan, and a 3Shape lab scanner, and comparing trueness, repeatability, and reproducibility. I will not go through the details here, but just to show the four centers involved, we did for PlanScan and for Trios and for the Sirona also. But most important is a little bit the conclusion, and that was showed in the last IADR session, showing that Trios offer a great dimensional accuracy, while the true definition scanner from 3M had a greater full arch accuracy. Again, a small remark that the bench scanning demonstrated a superior accuracy compared to all intraoral scanner, and this is very understandable. So let me give you some tips and tricks that are very beneficial when you are going to do intraoral scanning. One of these, again, this is out of any marketing here, but because they are the only company that are having this device, which is the Optragate from Ivoclar Vivadent. And I'll be showing here a small videotape just showing the placement of this. And you see it's an outstanding one to have a very good retraction of the sheep, and the patient still can articulate easily. Sorry. And you can see here that you have the corridors are totally free without using mirrors, without using any other device. And see, this is the intraoral scanner. This is a Trios 3 from 3Shape. And see, just to show you, it's so easy to use it without even any help. And we hope and we wish, and I'm sure we'll be having a new Optragate which is colored. Again, another tips is to use, you see these black reflectors that are used in photography, also to just take away the tongue, because the tongue should always be stabilized when you are having your intraoral scanning. So as you can see with the use of Optragate, here just will be back to this topic, because here you can see a scan body used for scanning implants, and the tongue that always should be stabilized. See, it's easy. You don't have to retract the cheek anymore. So going to intraoral scanning, and again, we don't have the time here just to go into all the small details and tips and tricks of intraoral scanning. But as you can see, so it's easy. In this case, you see it's difficult. It's more difficult when we are not placing our Optragate. This is why the use of Optragate is very important and very useful. And you see the final result on the printed model with a full zirconia crown, and you can see the same result intraorally. Again, you can see with Optragate, after prep, placement of, this is astringent from 3-IMSP just to do some retraction on the gingiva. And, you know, will not get, this is, again, this is a Trios 3 from 3Shape, and this is the old software. This is not the new one. But we were among the first people that have this machine. And you see the strategy of scanning, very fast scanning. There is a strategy that you should follow always when you are doing your scanning to have the maximum data needed. As you can see, this is a lower scanning. And again, the good thing about digital dentistry, about intraoral scanning, that you can check immediately about the information you have. If you need to readjust, to do some re-prep, and this is a huge advantage. Imagine that you are doing this with a conventional impression where you have to wait for the lab to pour the impression, then to send you, then to tell you, no, it was good, there is tearing, you have to change, and all these problems. As you can see here, we have placed a retraction cord. You can do it with retraction cord. You can use other also retraction paste. And see the scanning is very fast. Upper and lower, it can up to 2-3 minutes maximum. You can check the occlusion. You can check the clearance if it's needed. And this is also an outstanding advantage. And then you send your file to the lab. So a huge advantage when going into really and understanding digital dentistry. Again, cases that we show, you see the preparation, and we have showed this before. You can also use an electrosurgeon or a laser, whatever. It means we have all the things, just the most important thing, that the margin should be visible. We will be back to implants, so I will not be talking about it. Just to show you a little bit final results on printed models. Here, as you can see, with full zirconia monolithic translucent crowns, and you see all these are crowns made of zirconia and out of digital models. So the question that is always debated between dentists is about soft tissue management in intraoral scanning. So they will tell you, yes, but the scanner cannot see the margin, because especially if you are going into a subgingival margin. So the thing is that in the same philosophy that the scanner will just record whatever is visible. So you can use a retraction core for the people that are used to retraction core. You can use some retraction paste as astringent from 3M-SP, or also from Centrix, or you can go for electrosurgery or even for laser. So it again depends on the operator, but the most important thing, you have to avoid having bleeding, which is very important, and the margin should always be visible, because again, the scanner will just record what is visible. So even if you have a margin that is subgingival, if you put some retraction cord, you can again expose it to your scanner. So here is some laser just to show you. And one of the old trick, and this is the lowest cost in material use, is just to use air, your syringe. Because what you can do is you can use air, and with this air, while you are putting the air, you just get your scanner in, and you need just 1 second to record. Then what you do, you block this region, this zone, and then you continue scanning the other zone. And try it. It's a very nice trick that we like to use it, of course, when everything is clean, there is no bleeding. So moving a little bit on the smile design, we all know about the smile design that is out of wax up. So the lab tech, you take an impression to the lab will go and do some wax up, you take photography, and then they will go through some, like all the technique that were introduced by Dr. Kochman and other also well-known designer. But the problem that everything is done in 2 dimensions. So you always, after you're having a very nice smile design on the screen, then the lab will follow to do a very nice wax up on the model, on the cast. But when you go up to move into the intraorally by doing your mock-up, you will see that there is something wrong, especially on the canine and premolars. Why? Because that was a 2D wax-up. So, and the manual replication. So you have a lot of errors accumulated till you reach the end result. So, and this is why the most important thing is to always think in 3D, because also the scanners are moving into 3D. And nowadays, the labs will prefer to have 3D images. And just to show you that, especially now in IDS, in few weeks' time, a lot of companies are introducing their new 3D smile design by going into 3D digital. So you are integrating your design smile into the face, not only on the cast. And this will ease, and the lab technician will replicate exactly what the patient will see after doing a 3D smile design, not only a 2D, by merging the data on the face. And you can see some photos to show you how better is the integration in 3D smile design, because it integrates the move, the 3D, the face, and the different movement of the person. So now we'll be moving to one of the most debatable questions on digital dentistry, and mainly in dental implantology. So for digital dentistry, again, we need to go for an acquisition, mean intraoral scanning. You need to do a designing by using a CAD. And again, moving to the last chapter, which is the milling or machining or printing, depending on the case. So if we just do a comparison between the analog, it means within the conventional technique, and there is a different technique where you're taking an impression, and compared to the implant side, to the digital side, in which we have the digital model and we have what we call a scan body. Again, a scan body is used not for the precision as a lot of people think, it's just a positioning tool for the digital softwares on the lab side when it's taking and transferred from the clinic side, from the office to the lab. So again, the digital workflow needs scan bodies and digital analog, because you always have to think, you always have to synchronize whatever you are doing with your lab, because it's important that your lab have the library, the digital library, and have the digital analog in case he wants to go into printing. So, and you have to always be sure that the implant that you are using have all the components at both level, at the clinical side and on the lab side. So in this case, for example, we are using a scan body, an implant scan body from a company called Core 3D Centers. And you see that the scan body that is fabricated from polyethyl ketone material, and they have, you see the positioning, you see on the buccal side, you have this edge, and this will help the lab just to align it in his software just for the position again, not for the precision. So you can see in this case, and you see the scan body, the implant scan body, and the final restoration that will be back later on the different type of restoration. In this case, we just did both. We did the conventional impression, and you can see the analog, and we did also a digital one. And we, at the end, we finished by placing the restoration that were out of the intraoral scan that were done. So again, back a little bit to the literature and showing, comparing digital versus analog procedure for prosthetic restoration of single implant. And that was a randomized control trial for 1 year follow-up. And the conclusion showed that there was no significant clinical or radiographic between the digital and analog procedure. However, the digital workflow was preferred by patients because it's easier for the patient, and of course, it reduces active treatment as time and cost. Other also publication showing that digital technique showed superior outcome in comparison with conventional methods when comparing both. So again, you see that the literature, the data published in more and more on digital dentistry, especially going for intraoral scanner, showing that it's a precise and reproducible technique that is giving a precise outcome when compared to the conventional technique. So the thing is, one of the, let me say, drawback is in, and we'll see it later, and when we have a full mouth reconstruction on implant using intraoral scanning, and the problem is the distance between the scan bodies due to stitching of the scanning while doing it. But we are sure and we know that in the coming IDS again, there were several solutions that will be offered to solve these problems. So what about the precision of scan bodies? And this is also for the clinician, for the people, for the dentists that are moving into digital dentistry and intraoral scanning, they have to be very careful about. Again, not all intraoral scanners are the same. Again, not all scan bodies are the same. So again, you can see the reports, but one of the very interesting one is that the research with high quality seems to be slower. Why? Because the technology, the industrial progress is much faster. So you start testing and seeing, and up of a sudden you see that technology is coming very fast with novel products, with novel solution, which is very important. And the thing is, again, the problem is when you have a full mouth restored by implants when moving to digital intraoral scanning. So what the mistake that was from the company side when developing the intraoral scan bodies, they did it in the same principle as they are doing it for a lab scan body, which is different because the mouth, the parameters, the tongue, everything is totally different. And this is why we observed why we were doing, it means the clinical work. And you see here on the left side, this is the scan bodies. We took an X-ray to be sure that the scan body was well seated. But when we had the crown, we had like an elongation of the crown. And that was the problem coming from the scan body. So when we were asking ourselves why, we start seeing and feeling, and again, papers came out showing that due to the opening to the bottom of the opening of the scan bodies, it was creating some noises, and these noises were going to some deformation that lead at the end to a crown that was not well seated. So this is why, and trust me, we have tried a lot of scan bodies on the market, and you can see from different companies, and see we start seeing that the new company, the new scan bodies from company were coming with even no opening from this. You can see like from the Dental Smart solution, you see this one, and from Elos, again, another company that worked very good when you are dealing with Nobel BioCare implant, you see that they have reduced this open, but you need to use, again, a special key for it. So you can see that this opening is very small, and this is to reduce the noises and by so deformation. So just to show a case, this case came to the office, was treated here by Professor George Tawil and Dr. Peter Tawil, and implants were placed. And this is a case, as you can see, this is a full upper that will be treated with screw retained crowns on implant. And here we're multi-unit. So one of the solution is to go on the conventional one. You can use polyvinyl siloxane, you can use plaster, and move again to the one conventional analog procedure that you all know. And again, in this system, using the multi-unit system, or deciding to move into digital dentistry using intraoral scanner. And the question here, which scan body to use? Again, of course, we were choosing between three, and you can see this one, the one that is on the left, was one that is homemade by our lab technician. And what he did, he integrated into his library. And this is what we used mainly for this case. And you can see after getting the intraoral scanning, these are the homemade scan bodies, but they work perfectly, because the most important thing is that these scan body will match with the library and the software at the laboratory side. So you can see this is from the lab side, and he started designing the case. And you can see in this case, we decided to move into using CAD/CAM Chrome Cobalt. And here we move into the different material option offered from the lab side. So we go with pre-sintered CAD/CAM pre-milled Chrome Cobalt to zirconia, or to polyethyl ketone or PEEK. So in this case, we decided to go to use Syntron, which is a pre-sintered Chrome Cobalt. I will not go through longly this case, but you can see what you are seeing here is printed template that we screwed on the implant, and this will give us a little bit about the occlusal plane, the aesthetic. You can see, yes, they are in yellow. It's easier to see mainly. And if you decided in this case, we can just work on it, you can shorten it, you can adjust it, you can put all your remarks on this kind, and it's well fit, it's screw retained again, and these restorations were 3D printed. And you can see here, we can, from nothing, we have all this, as you can see it just by intraoral scanning. Again, we moved into CAD/CAM Chrome Cobalt, these type of Chrome Cobalt that will be sintered after doing the milling side. And see metal tri-in here, and ceramic application. And the final case, which is really acceptable from the aesthetic and fitting standpoint. But again, in these cases, we also went to some research with my student, from the doctor student, for CAD/CAM Cobalt, and showing that these type of pre-sintered Chrome Cobalt, CAD/CAM Chrome Cobalt, give a very good marginal and internal fit, and also a very good adhesion between the ceramics and the metallic substructure. So, but again, this will not offer a full digital workflow. Mean in this case, the case that we just showed, lab has to again layer ceramic on top of the metallic infrastructure. And this is not a full digital workflow. A full digital workflow where you don't have model anymore. So moving into zirconia restorations, and you can see for zirconia, and we have two options. One is to have for a full monolithic zirconia, or to go on a layered zirconia. But again, in these cases, you need to have a tie base to cement the zirconia restoration on it. So we have different type of tie base depending on the system you are using, and depending on the implant system you are using, and the different, again, because different company will offer different type of tie base with height, with different anatomical shape, most important with some retention to avoid any dislodgement of the zirconia restoration. Again, with this type of zirconia, that is layered, mean that these are not just infrastructure. We have observed some crack, some fracture. Why? And there is main two reasons. Milling discrepancy, again, not all milling machines are the same at the laboratory side. And the second problem is the tie base. You have to really choose the tie base with the appropriate height and appropriate shape. And most important, again, the way you bond it. And here we recommend to use the multi-link hybrid abutment from Ivoclar Vivadent that is really dedicated, that is specialized in cementing the tie base on the zirconia. So what about the monolithic concept? So we showed a little bit some cases with layered. What about the monolithic? And monolithic, this will help us to move into a full digital workflow. And we can move from a single implant. Okay, again, you use your scan body. You have your scan body, you do your scanning, you send it to the lab, and the lab will mill a monolithic zirconia, so no layering on this type, and then on the dedicated and tie base, they will just cement it, and you will have a screw retained crown on your implant, which is very good fitting, very easy to retrieve in case of anything happen, which is of course more suitable than having a cemented one. And we can see, we can show you a lot of cases that are done using this type of crowns, which are screw retained on tie base, full monolithic zirconia. So moving to another dimension in the full digital workflow is the use of polyethyl ketone, which is PEEK. Again, the literature start to move more on PEEK used as base. And again, we don't have a large experience, clinical experience in this, but hopefully in coming months we'll be more into it. You know, the main advantage with using this type of material is the weight. It's very, very light when compared to metal or to zirconia. And you can use it a lot for full mouths, for all-on-4, and you can just cement on top of it Emax crowns, zirconia crowns, or even you can put composite on top of it. And you can see the connection. And again, it's a milled process. So there is also the selective laser melting. So I will not go into it a lot, but again, it's one of the options that can be used in such technique. So again, I will end up this talk tonight. That was to show you that there is a lot of solutions offered with digital dentistry. With intraoral scanner, again, a lot is to be done more and more. A lot is coming. 3D printing crowns, additive manufacturing, robotic assisted. I'm sure that with the coming 4 weeks, and especially with the coming of IDS, a lot of new materials will be displayed, new of technique will be displayed. We'll be with you to show you all the novelties. Stay tuned on DentLinks, and we hope to be together very, very soon. Thank you very much for your attention.